So we're going to have a discussion about some of the regenerative biologics that have been tested primarily in phase 1 through 3 trials so far. I'd like to open this up to discogenic back pain. So our focus now will go from things like stenosis to discogenic back pain. So here's a disclosure slide. This is the world's amalgam of data. This is a systemic review by Wu, and this was published a couple of years ago in Spine. And so if you take 1,393 articles, there are essentially 6 studies with an amalgam of 74 patients for intradiscal cellular therapy directed toward discogenic back pain. So these are the highest quality data articles. If you look at them, these are the forest plots. I'm just going to give you a high overview point. So the average number of points in a VAS reduction is 44.2. If you want to normalize that to a numerical rating score, that's 4.42 points. So in most of the data analyses, if we have in the world of interventional pain, interventional spine surgery, if you have a reduction of 40 points or more, that's a home run. That's a shot over center field fence. The patient comes back to you and says, thank you, thank you, thank you. I feel so much better. And the average intradiscal or cellular augmentation reduction out of the best quality data says 44.2 point reduction in pain. How do we do in function? Well, very similar, because the average pain reduction is 32.2 points. And that from the Oswestry Disability Index, keeping in mind that 20 points is one category. So you move it a category and a half plus in terms of functional improvements. Here's some of the ongoing trials we have now. As you see, most of this is autologous. There's one allogeneic study that's going on. We do have, down at the bottom, this is a phase 4 trial, and the phases are listed in here. Most of these are 1 and 2. There's an ongoing phase 4, which is using FDA speak, drug approval speak. This is a post-market, so as treated, on label, ViaDisc NP, and we'll characterize what this is in ongoing slides. These are the new studies that have been completed. We have the massive Cascade trial, 404 patients, that's been completed. It's a phase 3 trial. The results aren't published yet, but I'll give you a preview on what those results are. The Vivex, this is the largest in terms of 218 patients, triple-arm randomized controlled trial. This is to compare it 3 times larger than the world's amalgam of data so far. And this has been published in Pain Physician, and we'll analyze those results here momentarily. I will also give you a preview of Discgenics nucleus pulposus cell that's hypoxically grown and cultured, and this is a phase 1/2 trial that's also been completed. So this is prelim results, non-published, but this was released in a press release. This is from the Cascade trial from Mesoblast. This is 404 patient randomized controlled trial compared against sham, which is an intradiscal injection of saline. And here are the results. 27.6 point reduction at 1 year, and at 2 years it's 26 point reduction. I tried to put this to normalize and compare from one study to the other. I have a percentage decrease. So percent-wise, this is a 45.7 point reduction, reduction at 1 year, and a 43% reduction at 2 years. Interestingly, if you break this down, all of these trials are for patients with chronic back pain as defined by back pain for 6 months or more. That's chronic back pain. If you take the level of chronicity up a notch and you analyze in the Cascade trial those that have back pain between 5 and 6 years or less, 68 months, or 5 or 6 years or more, and you take the patients that have slightly shorter duration of pain but still in the chronic back pain category, the results go way up. In terms of percentage relief, it goes up to 61% at 1 year and 60% at 2 years. And so with reductions between 36 and 37 points on the VAS scale. To transition into the VAS trial, I'm going to provide an explanation as to what material is being injected into the disc. So this material is called ViaDisc. What ViaDisc is, this is a bivalve disc, but the disc is harvested between end plate to end plate and ground into 300 micron aliquots. This 0.75 cc's, 3/4 of a cc, mixed with 1 cc of either saline for ViaDisc NP, or for the VAST trial, it was mixed with 1 cc of 6 million stem cells. This is from the disc material alone, so this is not inert material. This is a graft. This is an allograft coming from a tissue bank. And so if you measure what's in here, these are fibroblastic growth factors, hepatocyte growth factors. There are stuff in here. And they're also, this is a DAPI stain. You can stain it with a DAPI stain, propylium iodide. You can stain it for nuclear material, and it will have DNA, RNA within this. So as I mentioned, this is a mixture of what amounts to 6 million cells of a certain degree of stemness mixed with micronized disc material and injected through a 22-gauge needle. Current formulations are injected through a 20-gauge needle, and it forms what's akin to a thin paste and injected into the disc. This is just a mock-up of what shows injected into the center of the disc. It goes into the annular tears of the disc. And so we measure what are these cells? I mean, well, they have a certain degree of stemness, meaning CD73, CD44, CD90, SSEA4, somite-specific embryonic antigen. So these are precursor cells, and you inject them and you measure the count of the cells, and it was decided on a count of 6 million based on the traditional phase 2 type trials, primarily based on mesoblast, 6 million and 18 million cells in phase 2. As I mentioned, this was a 218-patient triple-arm randomized control trial, 3.5 to 1-to-1, ViaDisc, saline, and then we had the capability of crossing over. People that had conservative or non-surgical management had the capability of crossing over at 3 months if they needed to. Safety, these are the first 24 patients that were published in the International Journal of Spine Surgery. Safety was determined by anatomic analysis, x-rays, MRI, laboratory analysis, and reported adverse and significant adverse events. So I want you to look at the average age. The average age of this patient is 35.7 with a BMI of 27. These are not overweight. These are not elderly patients. These are young, healthy, good-looking people, just like the average audience of the Seattle Science Foundation first annual imaging-guided spine intervention course, right? Just like all of you guys, young, healthy, fit people. And this is who is affected by discogenic back pain. This is not vertebrogenic. This is not vertebral fractures. These are young, healthy people affected by discogenic back pain. So the results of this, remember, we compared this to Wu's systematic review. On the average, we get between 34 and 46.6 point reduction in pain. So this is profoundly good, and it certainly agrees with the Wu meta-analysis, is right in the ballpark with a 44.2 point reduction in pain. What about Oswestry Disability Index approval? Between 27.4 and 36.4, and this is the initial active allograft injections, and this is conservative care crossover. So these are people that come in that were enrolled in the trial and injected. The crossover people had non-surgical management first, and then were injected, very similar to what you would do in your practice. Person comes in, you wouldn't say, Mr. Smith, how you doing? I'm Dr. Beall. Look that way. Let me inject you with some allograft. You're going to do non-surgical management first, so some conservative care. If that fails, then you do testing with intradiscal injections and make sure you have the right level. Then you'll be doing the treatment. But this is very similar, up to 36.4 point reduction in pain as compared to the Wu meta-analysis of 32.2 points improvement in Oswestry. One of the interesting things about the VAST trial, it had an indication for 2 levels. 1 or 2 levels. So most of the trials we've done up until now have a single level. And I understand why they do that, to control the confounding variables. I understand that very well, but in our practice, we don't see cherry levels 3, 4, 4, 5. What do we see? We see 2 levels, 4, 5, 5, 1, right, Don? That's what we see. That's what comes in the door. And this is very valuable because we included purposely in this protocol a 2 level. So how do we do? We should have done worse because of all the confounding variables and the inability to control for this. No, and comparatively, it did better. Not significantly better, but comparatively better. The 2 levels did better than 1, which is an interesting thing, and that should be a take-home point when designing these protocols, writing the trial protocols. It's okay to include 2 levels, it appears, and this is, again, 3 times the world's amalgam of published data so far, and this has been published this last year, in pain physicians. So not only are 2 levels comparatively better than 1, performing better than 1 for pain, also in terms of function, performed slightly better. This is comparative data between the Cascade trial and the VAST trial for ViaDisc. We have seen the results, and I tried to include similar results. So 27.6 improvement for VAST and 17.7 improvement for function. In the Cascade trial is not quite as good as we see for pain and functional improvements in the VAST trial, but it is statistically significant. So all of these points right here are statistically significant. And this is Discgenics provisional results. These are not published. They have been presented at meetings. We're working on this 78-week proposal. I talked to them this morning about this, and this will be presented. So I'm showing you data that's not even off the press yet with this 78-week data. But to compare, we get functional improvements in terms of VAS up to 66.1. Discgenics was 62.8. So these are huge improvements in pain. I want you to call the label is high dose, 9 million cells. There was a lower dose of 3 million cells and a sham, additional non-therapeutic. So we have differing dosages similar to the phase 2 trial for Mesoblast. Just put that in the back memory bank for a second. And the Oswestry improvement was out to 23 points, down a little bit from 36.1 for the VAST trial. Also, we have Oswestry improvements that actually improve for Discgenics from 1 year to 2 years up to 30.8 points, category and a half. So the dose response, what I'm showing you here, was better for the 9 million cell category than the 3 million cell. In pharmacologic trials, we could call this a dose response curve. And so we get a dose separation of 9 million and 3 million cells. So this is in conclusion. So these are 2 large randomized controlled trials that show statistically significant improvements in pain and function. We have a large trial that shows a dose response. So we get the more cells you give up to a point, the better the response. And so this is something we like to see based on therapeutic efficacy of what we're injecting in there. So, and this is with a nucleus pulposus cell line that's cultured and given back to the patient. So the VAST trial shows significant improvements in function and categorical improvements that are significant in pain. And this is the largest published trial to demonstrate this. It's also the largest published trial to demonstrate 1 or 2 level improvement. So with that, let me show you a few examples of this. These are just points of interest. So this is modic change type 1 that resolved a month after injection. So what does this mean? Well, it means that the modic changes are gone or almost gone a month afterwards after injection of ViaDisc. This is something typically we don't see. We know modic changes do change over time. We know they can change rapidly, but outside of cellular augmentation of the disc, I've not seen this knowingly. It may have seen me, but I have not knowingly seen it. And we see restoration of signal within the disc. We see a shoring up or an improvement of the posterior margin of the disc over time. And as I show this from time point of enrollment to 6 months after injection, I have the VAS and ODI listed down here. So at least profound improvement. We see increased signal within the disc. And this is the slide that I had up on the very first introduction slide. And the patient is doing fantastic with a VAS and ODI of 0. We see also improvement of intradiscal signal. We see here reestablishment of some modic changes here that were not present at the time of injection. What does that mean? Well, what it doesn't mean is the patient is doing worse because of profound improvements of pain and function. But just to show you these cases where you have increased intradiscal signal. I've not seen this before. This is something that is novel to this. And what this means is that it's still undetermined what this is. I got into the intradiscal augmentation with cellular therapy through an ovine model, a sheep model. So chondroitinasis at 3 levels, saline at 1 level, carotid other level, and after the disc is degenerated in black, therapeutic components of one of these 3 that I've shown you that completely regenerated that disc from black to normal. So 2 points about that. Number 1, we are not sheep. We don't regenerate completely. Occasionally we see regeneration like this that are partial. The other component is the change in anatomic appearance of the disc and the end plates don't appear to have much relationship with clinical improvement. We have a lot of clinical improvement typically, as has been demonstrated, but don't anticipate that you'll see the changes. I'm just highlighting some of the changes that you can see possibly. Shoring up of the posterior margin of the disc, small extrusion that goes away, and reestablishment of some of the signal. And, when should we do this? When should we wait till it's very degenerated? Should we do it earlier on? This is reserved for modified Fearman grades 3 through 6. We didn't have a monitor, a medical monitor, and as it turned out, we left it up to the investigator's discretion as to what to enroll, and we enrolled lots of Fearman grade 7 and 8. And so we've had patients that received intradiscal augmentation that were modified Fearman grade 7 or 8, very degenerated, and they did at least as well as the 3 through 6 category, which is moderately degenerated. So maybe we didn't know as much as we thought we did about who is the ideal candidate. The other component of that is maybe we don't need to worry so much about who the ideal candidate is because it works on apparently all degrees of disc degeneration, but the jury is still out. So we don't know what we can inject it in. Apparently it works for lots of disc degeneration. Do not expect to go from a Fearman grade 8 to a 1. But do know that this provides substantive relief and improvements in pain and function, and this is going to be a promising technique for the future. That is it. I think we can open it up to some questions and comments.
Doug, this is Neil. What diagnostic criteria did you use to establish which level or levels you were going to treat?
So diagnostic criteria, chronic back pain, we used MRI and we limited it, tried to limit it, modified Fearman grades 3 through 6, grades 6 to 7, 6 is up to 30% collapsed, 7 is more than 30% collapsed. I did discography on every single patient. And we didn't require discography. We used imaging in combination with so the physical examination parameters. So if you are under 50, we used sustained hip flexion primarily as a physical examination, and MRI findings of a disc that's degenerated that correlates to the patient's physical symptoms. Just these criteria alone puts you at 94% positive predictive value for discogenic back pain. We did not require discography. My opinion is I don't like injecting a disc or doing any treatment unless I know that's the point of pain. So what I do is a combination of anesthetic and provocative. I use a cc of 4% lidocaine. I use another cc of dexamethasone. I inject it into the disc. Ask the patient as I'm injecting, is this the same as your typical pain that bothers you? If the answer is yes, that's a provocative discogram positive, yes, in the positive category. Then we wait just a few minutes to see what happens. And if somebody has discogenic back pain and vertebrogenic back pain for that matter, you inject 4% lidocaine, 1 cc in the disc, the pain will go away. So positive provocation, the pain goes from a 7 out of 10 to a 0. How sure are we we're in the right spot? In my mind, I'm 100% sure. So hopefully that's more, is less occasionally correct, but never in doubt. But I believe in injecting the disc and determining either with a provocation or an anesthetic discogram, preferably both, that we are in the right spot. Yes?
So I noticed the placebo, the saline injection, still had pretty good improvement.
Pretty good improvement.
Is there any like mechanical or biological reason for injecting saline for the patient, and maybe that's not the best placebo? maybe it's actually having an effect besides the mental effect.
So I categorically agree with that. I think that's I like your observation. It's very astute. You're paying attention because I put it at the bottom here to demonstrate that placebo should be a placebo. And saline is no placebo. The placebo here has outperformed the active treatment in some of the legendary treatments that we now employ on a daily basis. So why is that? Well, I can tell you that there's quite a bit of literature on the fact that we shouldn't be using saline in the disc as a placebo. So what does it do? Well, maybe it washes out the inflammatory mediators. Maybe it hydrates the nucleus pulposus. Maybe it resets the zeta potential in the disc, all of which it does. Does it really matter? It's probably a combination of all of these, maybe some additional elements thrown in there, but it causes improvement. You know, back years ago, I used to do therapeutic injections of normal saline because it helped people. I've kind of stopped doing that now that we have active treatment for cellular augmentation. We have basivertebral nerve ablation for vertebrogenic back, but we have stuff that we can do in the disc, and so I've stopped doing that. But this is a known thing that saline improves intradiscal discogenic back pain. So, yeah, I mean, I left that up there because there's only one criticism in the VAST trial is that some points in pain were not statistically significant, and they said, oh, you didn't meet your endpoints. Well, you know, we did have statistical significance in terms of pain and functional improvement in both categories, but in some of the responder groups. The reason it wasn't positive all the way across the board is right down there. A 45% reduction in pain with a placebo at 1 year, and 21, a whole category of Oswestry improvements. I mean, to beat that across the board in terms of statistical significance, you know, you'd have to be up there with magic miracles and whatever form of treatment you had. I mean, this is an impossibly high bar. And given that, when you compare these across the board, and that's why I wanted to compare the big trials that have been done, these response, I would say categorize these responses, they're not good. These are excellent in terms of back pain improvement and functional improvement.
I'm trying to remember back. Did you analyze the group that was blinded to the allograft and conservative care, and separately than the ones who crossed over?
Yeah, so the allograft, the initial is up top, and the second one was the crossover. So the ones that received the crossover did so on label, if I could use that. I know this doesn't have a label, but if it did have a label, it would be on label use. So they knew what they were getting. So, and in terms of crossover, we didn't have a single person that didn't cross over. That's the downside about allowing a crossover, is everybody will cross over. So people, I don't know your experience in treating discogenic back pain with non-surgical management, but my experience is it's terrible. People have persistent, ongoing pain, can't sit, can't drive, bending at the waist hurts them. So this is something that, to no surprise, there was a huge amount of crossover. But it's very difficult, at least in my opinion, to ethically conduct these studies without allowing something. You know, to have an 8 out of 10 back pain for 2 years, I mean, it's inhumane to allow that, I think. Questions, comments? Okay, we're going to transition now. We're going to have